Chris Garrity here from Aspire Mental Health, and I am super excited to begin the next episode of my podcast series, which is all about post-traumatic stress disorder, or PTSD for short. And today we're going to start with a high-level overview of PTSD. We're going to define the terms, and we're going to help get you acquainted with the disorder from a perspective of a mental health clinician. But the real work is going to come further down the road in part 2 and beyond, when I'm going to break down all of the little signs and symptoms of what you can track in your loved ones and how it uniquely manifests itself in all of the people we care about. But most importantly, how we can be the agents of change we want to be in their lives. So join us here today as we start the first leg of our journey and start defining post-traumatic stress disorder. So here's a review of the diagnostic criteria for post-traumatic stress disorder, and it's really important that we review criterion A. So there has to be some kind of exposure in some way to a trauma, and the DSM is pretty explicit here. Death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. And that really can be experienced in a wide variety of ways. And this is so important. The modality of exposure can be very, very diverse. I'm going to emphasize that. Very, very diverse. So direct exposure, for sure. Someone has a grave bodily injury or receives a threat of bodily harm that activates the fight or flight system, that can definitely count as an exposure to trauma, but also witnessing the trauma in other people, witnessing somebody injured on a battlefield in a war, even though you're not injured yourself, can definitely be a root cause of PTSD. But also learning that the trauma happened to somebody, both a close friend or relative, or indirectly through the course of professional duties. For instance, a medic treating trauma survivors off of the front lines. That medic may never have exposure to any of the kinetic part of the war, but in reality, they still can develop PTSD through the lived experience of simply caring for trauma victims in a hospital that's off the front lines. Even psychiatrists or psychologists have been known to develop PTSD simply by listening to the trauma of a patient. And that's a really important takeaway. So moving on to criteria B, the traumatic event is persistently re-experienced in at least one of the following ways. So a person can have just one or all of these types of re-experiences. The first being unwanted, upsetting memories. And these are often intrusive or dark thoughts that the person simply can't get out of their mind. They can be very effective at derailing their day. The next would be nightmares. Nightmares are very common. They can either be consistent nightly events or episodic, and they often accompany, extreme amounts of movement in the person's sleep. A lot of times partners of individuals with PTSD will come to me and say, "Hey, can you write me a prescription so I can sleep better because my partner doesn't stop thrashing around at night?" And obviously, this can be not just debilitating for the patient, but also very debilitating for a spouse. Next is flashbacks. And flashbacks are often visceral, very physical re-experiences of the original trauma. And again, these can be very decompensating for the person who experiences them. Next is an emotional distress after exposure to traumatic reminders. And oftentimes this comes in the form of some trigger that can either be subtle or direct. Over the years, I've seen a lot of this. For instance, a soldier who is simply reminded of an aspect of war all of a sudden has their day ruined because they isolate or can't get out of bed or become really debilitated in a very serious way as a result of that trigger. And last but certainly not least would be the physical reactivity after exposure to traumatic reminders. And this is often a response, a physical response to a trigger such as a panic attack, an anxiety attack, or extreme restlessness. And all of these ways can be very, very debilitating to a person and certainly interfere with their quality of life. The next criterion C, is really important, and that is avoidance of trauma-related stimuli after the trauma. And this really means that the person engages in a pattern of behavior that is heavily avoidant of anything that could possibly remind them or force them to confront the trauma that they had previously experienced. And this can be avoidance of trauma-related thoughts or feelings, or avoidance of trauma-related reminders like triggers. And this is actually what really makes our job as clinicians really difficult, is because many people with PTSD will not talk about it, they will not want to open up, and they will not want to touch or re-examine their trauma in any way, although real healing and progress comes from doing just that. The next criterion is criterion D, which is all about negative thoughts or feelings that began or worsened after the trauma. And they really have to happen in just 2 out of the following 7 ways. But this is really a great example of just how diverse and unique a person's PTSD can be, because there are so many different thoughts and feelings that begin and worsen after the trauma. The first is an inability to recall key features of the trauma. And this is really common when someone starts therapy. They simply can't remember parts or even all of the trauma because the brain suppresses that part. PTSD activates a physiological response in the body's fight or flight system, and the body really does not want to activate that. So it will work in very unique ways to suppress the memories of the trauma to prevent that activation. The next would be overly negative thoughts and assumptions about oneself or the world. And this was really about the person believing that the world is overly negative. Everything is about different dark shades of gray, and the glass is always half full, half empty and never half full. And this can be very, very noticeable in someone with PTSD. The next is an exaggerated blame of self or others for causing the trauma. And this is super common. Someone oftentimes blames themselves for all of the consequences downstream of what happened in or after the traumatic event. And most of the time, the originating trauma had simply nothing to do with the person, and they were really a victim. And I think this is what makes what makes PTSD really sad, is that a person with PTSD oftentimes takes the weight of the world on their shoulder. Or on the flip side, they can actually blame other people and attack them verbally for causing the trauma. A lot of times we see an exaggerated blame for or against other people who had maybe nothing to do with their lived experience, but nonetheless are the object of their disdain. Next is a negative affect, and this is really in many cases, either a sad or blank expression on their face. It can be negative or flat. And this is a very common lived experience every day of someone who carries the weight of PTSD. And this accompanies the next criteria, which is a decreased interest in activities. Another way of describing this is anhedonia. This, again, is very common. And is actually mistaken as clinical depression in many cases, but is very unique in that the lack of interest or joy in any daily activities is because of repressed trauma that's inhibiting that. The next is feeling isolated, and this is not just a feeling, but often a physical reality, is that people with PTSD feel like they are on an island, and they act like they're on an island. In fact, they isolate away from other people, and they don't engage in activities or hobbies that they once enjoyed. They may spend all of their time inside. They may feel like they are not connected to other people in any meaningful way. And the lack of connection, just further perpetuates the physical isolation. So that is a very, very life destabilizing symptom. And last is difficulty experiencing a positive affect. And this is really just difficulty expressing any type of joy on their face, or being joyful in any meaningful way. It takes really just a lot of extra effort. The next criterion is trauma-related arousal and reactivity that began or worsened after the trauma in the following ways. Irritability or aggression. This is a very, very impactful set of symptoms of a person who suffers from post-traumatic stress disorder. Oftentimes they engage in risky or destructive behavior. Lots of times that can take the form of vandalism, destroying property, destroying their own property, going out and driving really fast in their car in a self-destructive way just to feel alive. A lot of times that is a very big part of their trauma processing, and even avoidance is that they're engaging in self-destructive behavior simply to avoid having to deal with reality in a way that could force them to confront something uncomfortable. Hypervigilance is another hallmark symptom. Hypervigilance is always being on guard or on edge, fearing for your safety. A lot of people with PTSD will say, hey, when I sit in a restaurant, I always make sure I have the exit door in sight. I always have an escape route in case something happens. And this is unfortunately very common in women who are victims of domestic violence. Next would be a heightened startle reaction. And this is really exactly as it sounds, is that people with PTSD are very quick to startle. Even small, soft noises can evoke a very powerful startle reaction in somebody with PTSD. Next would be difficulty concentrating. Focus issues are very pronounced in PTSD. You have no idea how many times people come to me and they are convinced they have attention deficit disorder because they can't focus, but in reality they have post-traumatic stress disorder. So I always encourage both my students and my colleagues to really be diligent about screening for PTSD at intake, because concentration problems can really have multiple sources. And last, but certainly not least, is difficulty sleeping. As we've already talked about previously, nightmares are abundant in PTSD, but difficulty falling asleep and staying asleep independent of that is still oftentimes a very dangerous reality for people with PTSD. The next set of criterion are pretty simple. The symptoms have to last more than a month, and that's pretty routine. Oftentimes they last a lifetime. The next is that the symptoms create distress or functional impairment. And the last one is that they're not due to a medication, substance, or other illness, which at times can be a little problematic because sometimes people do abuse substances as a result of their PTSD. So we always want to be extra diligent in seeing what is caused by the PTSD versus what could be caused by any substance abuse involved. And lastly, this is very important. I want to talk a little bit about some what we call specifications, or for lack of a better term, subtypes of PTSD. Dissociative specification is something that is very common in PTSD. Some people with post-traumatic stress disorder have either depersonalization or derealization symptoms. Depersonalization is oftentimes described as someone who feels like they're outside of their body or detached from themselves in some way. In other words, they often feel like their life is kind of a dream. Sometimes people will describe that their vision is literally akin to looking down a tunnel at times. And they describe their life as if they're living it through someone else's eyes. And anytime we hear this, we immediately screen for PTSD if we already hadn't done so. Next is derealization. And this is really an experience of a lack of reality or just a distance or distortion of life itself. Many of these types of symptoms can be difficult to explain and certainly difficult to conceptualize for someone who doesn't experience them. So a lot of times partners or loved ones of individuals with PTSD will really have a difficult time empathizing with some of these more bizarre sounding or experiencing symptoms. But to the person who is living with them, they certainly can create a lot of hardship. And last but certainly not least is what we call the delayed specification of post-traumatic stress disorder, is that oftentimes when somebody experiences a trauma, none of these symptoms may happen right away. Sometimes they happen more than 6 months or years later. And that is a really important distinction here, is that a person may be completely normal for an extended period of time after experiencing a trauma, but that certainly does not rule out the possibility of PTSD in the future. So to wrap things up, next week we are going to take a look at the different types of trauma and how different types of trauma can really create very unique versions of PTSD. We're going to look at specific lived experiences of individuals who have it. We're going to understand how to better track someone's distress, maybe get a little bit better at figuring out when things are going to be more difficult for people with PTSD. And lastly, we are going to really take a close look at intervention strategies and how we can be catalysts for change in their life. So thank you so much for joining me here today, and I look forward to seeing you soon.